Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fardon. I'm the chair and organizer of Grand Rounds. We are returning to our microbiology, infectious diseases, public health sort of vein that runs through the talks for the next, well, a couple of weeks ago and into the rest of the autumn. But today we're returning to Mpox. So we had a talk about Mpox from the team previously. There has been changes in the context of Mpox. There's been a change to its name for one thing, but we're now due for an update in what it is, where it is, why it is. Should we be worried? In whom should we be worried? What to do if we suspect a case of Mpox? Who are the people to contact? Who are the key folk? And what should we do about it? So today we've got a range of speakers. So I'm grateful to everyone for making the time to come along. And Simon Hilton is going to kick things off, then Daniel Chandler. Nick Ray from Infectious Diseases is going to speak, and then there's Kira and Pam and Amanda, I think, are rounding things up. So they've got all this planned, they'll keep themselves right. If you have a question, please do put it into the chat box. We can get through the questions at the end, or you can wait and put your hand up, be brave, and say something on screen. The Grand Round program, I'm pleased to say, is full all the way till Christmas. But if you're sat in the audience thinking you've got a great topic you'd like to bring to the group for 2025, please do get in touch with me, email or just send me a message, and we can give you a slot on the rota for next year. So with no further ado, I think Simon first, an update on Mpox. Thanks so much.
Great, thanks, Tom. Can I just check that everybody can hear me okay?
Yep.
Yeah, I'm getting two nods. That's great. Thank you. Okay, so thanks very much for that, Tom. So as Tom said, there's a few of us who will be speaking to you to give you a range of perspectives on Mpox. I'm going to kick off just trying to set the scene a little bit, really, and we'll tell you about some of the public health aspects, some of the clinical aspects from an ID, sexual health point of view, IPC point of view, and lab testing point of view. I'm Simon Hilton. I'm a consultant in public health medicine, the health protection team, and Associate Director of Public Health. Hopefully everybody can see the overview slide there. You can see the slides moving. Yeah, great, thank you. So, as I say, we all, because there are so many of us, I've been banging on to everybody about how quick we all need to be and brief and concise, so I need to try and set the tone for that. So I'm just going to really briefly give you a bit of background context, just in terms of Mpox and what it is. And then the current international situation that's causing concern, what we're doing nationally to prepare for that. And then I'll hand over to Danny, who will tell you a bit about community prevention and control, and then he'll hand over to Nick, etc. But I think I'm in charge of the slides, so I think all the speakers might need to ask me when to move slides, possibly. So I need to keep fully on the ball for the hour. So just briefly, because we talked about this, as Tom said, back at Grand Rounds in 2022, Mpox is a viral zoonotic disease, comes from the same, caused by monkeypox virus, which comes from the same family and genus as a number of other pox viruses. Called monkeypox because it was first discovered in research monkeys, but was then changed to Mpox. And there are two clades, clades 1 and 2, and each clade has two subgroups, A and B. It generally occurs in Africa mostly, and prior to the outbreak we had in 2022, there had only been one outbreak reported out with Africa in the USA due to importation of animals. We had experienced a small number of cases in the UK, mostly travel related, but then in 2022, as Tom mentioned, we had a more significant outbreak of clade 2. I'm not going to go into that in any detail because I think Kira's going to tell us a bit more about that. But I think important to note that certainly prior to the 2022 outbreak, monkeypox as it was then was considered to be a high consequence infectious disease, or HCID. And essentially this puts it into the same category as a number of other infectious diseases, for example, Ebola virus, which meet a number of criteria, some of which are that these are generally diseases that have quite a high severity rate in terms of morbidity and mortality. They're difficult to treat. They're not things we see very often in the UK. And there are a number of other criteria as well that constitute a high consequence infectious disease. But essentially what it means is that these are diseases that we pull all the stops out when it comes to trying to prevent transmission. On the back of the 2022 outbreak, clade 2 was actually de-designated to being not an HCID, but clade 1, importantly, remains an HCID. Oops, sorry. So in terms of the international situation and the concern that is there at the moment, this is because of a large number of cases of clade 1A being identified in the Democratic Republic of Congo, really over the past calendar year, maybe a bit less, maybe about sort of 7 or 8 months, and surrounding countries. And increasingly we're seeing cases of clade 1B as well. And the concern really centres around that the rate of spread appears to have been really quite rapid. There is a much wider community affected, so a much bigger pool of vulnerable people than was experienced with the 2022 outbreak. And there's been a lot of concern that there was a high level of severity and mortality reported, particularly in children. And so in August this year, the WHO designated this, the outbreak, a public health emergency of international concern. It is very much an evolving picture. Particularly, there are questions being raised about the case fatality rate, but I'm going to show you some data just to demonstrate that in a minute. And also around the transmissibility. We know that certainly there's significant transmission through indirect and direct contact, but there's less certainty around the airborne route. And obviously that has quite a significant impact on transmissibility. So I'm just going to show you a few pictures and bits of data just to sort of try and explain what's going on. So this first map here, it's important to look at the dates at the top there, because essentially this is over the past 3 calendar years. And this is really just to show the distribution of clades in Africa of Mpox. And the country there with the blue and green stripes is the Democratic Republic of Congo. And that's just showing that there are clades 1A and 1B detected. And it's really just sort of showing that clades 1A and 1B really are around this kind of Central African region, with most of the other Mpox experienced in Africa being in other countries in the West, but also in the North and South as well. This map is more recent. This is over the past year, or at least over a shorter time period, the past sort of roughly calendar year, 10 months. And it's really showing particularly this dark blue and the Democratic Republic of Congo. It's showing the number of cases, and it's just showing just how many cases there have been, the significant increase in the DRC during the past calendar year, and to some extent in the surrounding countries, but especially centred on DRC. And this is putting some of that into data and figures. And just to explain this, so the boxes, the light blue box and the light pink box with the asterisks in, they are suspected cases and deaths in suspected cases. The darker boxes are lab confirmed cases and deaths in lab confirmed cases. And I think there are a few important things to note here. So first is the significant number of suspected cases. But obviously the number of lab confirmed cases is significantly smaller, and you can see in the text at the bottom there that less than half of the cases in DRC have actually been tested, and of those that have been tested, there is about a 50% positivity rate. But what's also really important to note here is the deaths. So in terms of if you compare the light pink box, deaths in suspected cases, with the darker one, the deaths in lab confirmed cases, there really is a sort of a magnitude of difference there. So in other words, suggesting that actually maybe the number of deaths or the proportion of cases who actually do die is potentially significantly lower than was maybe originally thought. And I think that's what's raising some of the question around that. And then interestingly, if you look at Burundi, which is the next most affected country, which is just on the eastern border of DRC, there have been no deaths actually reported in lab confirmed cases so far. This is just a trend graph, just showing again over the past calendar year, really, cases. Important, so this is weekly cases, but it's also lab confirmed cases. So important to note that. And really, I think 2 take-home messages from this. One is that really the vast majority of cases are in DRC, which is in red there, and Burundi, which is in blue. But it also shows this increasing trend. The sort of line at the top right-hand corner there is just really making the point that some of the more recent data there is less certainty around. But I think you can see from the graph overall that there doesn't really seem to be any suggestion of the rate of increase slowing, if anything, potentially increasing. But as I say, there is that uncertainty around some of that more recent data. And then lastly, I was just going to mention briefly before I hand over to Danny about national preparedness. So there is lots of preparation going on in the background at both UK level versus through the UK Health Security Agency, and Scotland level through Public Health Scotland. And there is an ongoing Scottish National Incident Management Team, under which a number of cells sit, and those cells address a number of key considerations, including public information and surveillance, clinical pathways, how to manage cases of Mpox or suspected Mpox, contact tracing and vaccination. But I think Danny's going to tell you a bit more about these, so I'll hand over to Danny. Thanks, Danny.
Thank you, Simon. So I'm Daniel Chandler. I'm one of the other consultants in public health based in the health protection team. I've got 4 slides which are a bit wordy, so I'll do my best just to summarise as I go through them. As Simon says, there's been a lot of work already happening and continuing around preparing for and managing UK responses through public health channels. And there's a number of layers to that. Firstly, the idea of preventing and detecting cases at the point of them potentially arriving into the UK is part of the initial approach to managing the risk. And so that is what's known as case detection or border control at that level, and reflecting the fact that there have been already 3 cases of clade 1b disease detected outside of Africa, all with relevant travel histories, and those are spread across Europe and Asia. So it's a matter of planning for something we can expect to happen at some point. It's more of a when than an if. But to try and reduce that risk and the volume, there are mechanisms including in-flight health questionnaires and screening for travellers who are coming from affected countries. Also information and posted at airports now, including in Scotland's airports where there may be connecting flights to the affected countries arriving, to give people advice about what to do if they have relevant symptoms. And we also have what's known as a returning workers scheme. So for any UK-based healthcare or other professionals who are going out to support the response in the outbreak countries through organised aid agencies and similar, or it may be governmental workers, they will be followed up and monitored by public health services as they return into the UK for any emergence of relevant symptoms. Beyond looking at the border, if we want to try and maintain a level of awareness and responsiveness in the general community, including through healthcare workers, we do that by ensuring we have appropriate public communications and information provided, and that's an ongoing exercise which will align to the changing risk profile and assessment of likelihood of importation of cases. Public health teams have been supporting developing definitions for cases and the prompts for public health action in the community, also supporting colleagues, which you'll hear more about today, locally and nationally, in developing clinical pathways and implementing those. And if and when we do have a case locally, then the public health team here will have lots to do in terms of supporting isolation in the community where appropriate, completing surveillance questionnaires to find out as much as we can about possible sources and routes of exposure and onward transmission. And that includes following up any contacts that are identified. And at the more strategic level, public health teams are also involved in planning for various scenarios that we might come on to deal with. So if and when there is establishment of Mpox in the UK with potential for community transmission, then we need to be prepared for responding to that through additional public health measures. And vaccination is part of that as well, which I'll talk a bit more about. Next slide, please. So I mentioned case definitions. These have been developed at UK level with coordination between all the relevant public health agencies. It is an evolving set of definitions and it's available online publicly. So I'll do my best to give you a bit of a feel for what the essence of these definitions is. Nick will also talk a bit more, and I think Kira as well, about the specifics. But in general terms, Mpox is suspected at this time where you have a patient who has prodromal set of symptoms, and I think you'll hear more about what that is, plus an epidemiological risk, i.e. contact with a confirmed case or a suspected case in the 3 weeks prior to the onset of the prodrome. So that's one scenario in which to suspect a case. It's a prodrome plus an epidemiological risk or association. We would also suspect Mpox where you have an Mpox compatible rash. So that's beyond the point where the prodrome only is clinically presenting, and or proctitis. And again, it's with an epidemiological factor within the previous 21 days. And that might include, as well as a relevant travel history or contact with a known or suspected case, any new or recently new sexual partner being reported, or a link to infected animal or meat products, which again, there's more information about through the links that this case definition set is provided from. The response can be also aligned with a suspicion of clade 1 disease specifically, relative as distinct from Mpox in general. There is a big overlap between these two definitions, but this is termed what is the HCID operational case definition. So this is where you suspect not only Mpox, but clade 1 disease, which is a HCID. And that's really where you've got some of the features mentioned in the general suspicion case definition that would tie it to being clade 1 in particular. So a travel history to one of the relevant countries, or a known link to a confirmed or suspected case of clade 1 disease specifically in the previous 3 weeks, or a zoonotic link, so a relationship with or exposure to a wild or captive animal or product from those that is essentially an African native species. So there's a lot to think about there, but it boils down to a plausible epidemiological risk or of exposure plus relevant symptoms. Next slide, please. So if and when we do have a report of a case or cases within our local patch, the public health response will include a number of things that you might be able to anticipate. Amongst those is gathering as much information as we can as possible about the case and how they might have been exposed, and anyone else who might already be at risk of developing the infection as a result of that. If the person doesn't need to be admitted for clinical management, then they'll be isolated at home with support. So they'll be asked to limit contact within the household as well as externally. Look after their own hygiene and cleaning and so on to try and minimize the risk of spread within their household. And the minimum for lifting those provisions would be for fevers to have subsided for at least 3 days and no new skin lesions for at least 48 hours, with lesions having scabbed over. And there's a bit of extra caution around skin lesions that are on exposed skin, facial or upper limbs, basically. We will be identifying contacts. That's primarily household or sexual or intimate contacts, but also there may be healthcare associated contacts. That's where Pam and her team come in. But there's also a risk where a shared, particularly indoor environment, is reported with close proximity between the case and the contacts. And in the case of any contacts, we'll be offering them advice, supporting them to report any onset of symptoms, and provide reassurance and links into care if needed. We also would conduct passive monitoring, and that's similar to the returning workers because they are in effect potential contacts. So we would give them clear information about what to do if they do develop any symptoms, how to report that, and how to get further help in a way that means they're not exposing others without appropriate precautions. Next slide, please. I think this is my last one. Vaccination is a key element of the overall public health response and for mitigating risks, both for individuals and the population as a whole. You'll be aware that there is a vaccine or vaccines available. These are essentially vaccines that were developed to protect against smallpox, but because they're from the same orthopox family, smallpox and Mpox, the vaccines have good effectiveness in protecting against Mpox as well. Supplies are relatively limited at a global level, so careful management and prioritization of the usage of the vaccines is the order of the day. And that includes where possible, giving the vaccine as a fractionated dose intradermally as opposed to the standard subcutaneous or IM route. That means you can get essentially 5 doses out of each vial instead of 1. But that depends on careful scheduling and appointing and management of people in to get vaccines in the same clinic, basically, because once the vial is opened, it's got quite a short time span before it becomes non-usable. So those who are eligible for vaccination broadly hasn't changed since 2022. And again, Kira will talk a bit more about that program. It's high-risk GBMSM and also certain occupational risk groups, including those who might be working in HCAD type environments and or who might be going out to support the response to the outbreaks in Africa. We would also vaccinate certain high-risk contacts following exposure where appropriate. Usually that's within 4 days, but it can be within 14 days for contacts who are particularly high risk in order to reduce the risk of them developing more severe disease. In the event we have a more widespread transmission and outbreaks in the UK, then nationally, the response that would be considered would include a broader range of vaccine recipients, wider household members, not just contacts, but contacts of contacts, and potentially what are known as ring vaccination strategies. So within particular communities and environments, vaccinating everybody, and that's to try and catch up to the transmission that may have already happened before you've become aware of it through somebody presenting. And that style of response was important in the global effort to eliminate smallpox, which you'll be aware of one of the major public health successes of the 20th century. So some of the same types of intervention could work as well. And there are a number of scenarios that are being thought through at national level with public health and clinical colleagues to be prepared for, ranging from the less severe to the most severe, from occasional single cases or small clusters, which do not result in sustained transmission in the UK, to a more substantive epidemic, which is manageable, versus ongoing and effectively uncontrolled community transmission. And the scale of response from the NHS and wider systems will obviously be tailored to which of those. And I think it's too early to say which is most likely to be the final position we end up in, but obviously we're working and hoping for something more like scenario A than C. I think that was my last one, so over to Nick.
Thanks for that. I'm Nick Ray, one of the ID physicians, so I will just very quickly chat about Clade 1 clinical aspects. So next slide, please. Let Chris Whitty here. So just a brief chat about the phases of clinical illness. As was alluded to previously, there's this kind of prodrome, which is very, very typical, lasting a period of a few days, up to 5 days, but quite severe, high fever typically, and kind of almost a kind of influenza type illness with headache, back pain, myalgia, fatigue, and very characteristically lymphadenopathy, which is really, really a strong indicator for Mpox, in contrast to many other diseases with cutaneous manifestations. But lymphadenopathy features heavily in case series of Mpox. I'll touch upon that in a few minutes. This prodromal phase then progresses into a second phase, which tends to occur once the kind of high fever subsides, and you get this evolving rash, normally starting on the face and progressing onto the trunk and palms and soles, following this kind of general pattern of macules turning to papules, becoming vesicular, and then pustular lesions, before umbilicating, crusting, and eventually desquamating. And that, generally speaking, happens over the space of a couple of weeks. Next slide, please. So this was some data actually from DRC, mainly looking at cases of Clade 1 Mpox, and just giving you a flavour of the predominant symptoms that were identified. So rash, unsurprisingly, given the illness, was almost universally reported. Malaise and sore throat being the two other symptoms that were reported by patients. And on findings on examination, the classic Mpox rash was overwhelmingly present, and lymphadenopathy was again extremely common. Most commonly cervical, but also inguinal nodes. Often it may be a kind of generalized lymphadenopathy that is found. And mouth and throat lesions were seen in a kind of minority of patients. Next slide, please. These are just some photos, both from CDC and from a publication from the High Consequence Infectious Disease Network in the UK, just highlighting some of the different kind of presentations and differences even in skin pigmentation in terms of appearance of lesions. But you can see some lesions that look very much more pox-like, some that look a bit more pustular, and some that almost look kind of macular there, and the kind of pictures in the center on the palms and soles of the feet. Next slide, please. And this is some kind of again some photos of Mpox lesions showing different forms, if you like, ranging from the papules to the vesicles, the pustular lesions, the lesions that have then kind of crusted, kind of fallen off or umbilicated. Next slide, please. Differential diagnosis is obviously quite wide, predominantly herpes virus infections, so chicken pox or primary HSV may be commonly mistaken for Mpox, but hand, foot and mouth disease, syphilis, disseminated gonococcal infection, particularly those kind of pustular type lesions, measles, scabies, and arboviruses, which are arthropod-borne viruses, so viruses spread by vectors, dengue, Zika, chikungunya, again, can produce more of a macular kind of rash. Again, it wouldn't be, I wouldn't expect the appearances to be typically kind of exactly the same, but maybe in the early phase, maybe confused with Mpox. Next slide, please. Complications are quite widespread. Bacterial skin and soft tissue superinfection is well reported, and certainly was a feature that was reported in some of the 2022 cases. Deep subcutaneous abscesses requiring drainage. You can develop shock through a variety of mechanisms, either through subcutaneous accumulation of fluid during the kind of crusting phase, or from GI losses and through vomiting, diarrhea, or like kind of fluid sequestration in the gut. There may be widespread exfoliation of skin that can, in severe cases, require surgical debridement and skin grafting. And again, the severe complications like severe pneumonitis, ARDS, keratitis causing visual loss, and kind of fulminant infection with septic shock and encephalitis are rare, but are more commonly reported in clade 1 cases. Next slide, please. Predicting complications is tricky, so we know that through the literature that children, particularly young children under the age of 12, are more likely to develop severe complications from Mpox, and pregnant patients. But immunocompromised stages, particularly advanced HIV infection, uncontrolled with antiretroviral therapy, is a significant risk factor for a poor outcome in Mpox. The clinical features, again, that have been described through observational studies in Africa, suggest that vomiting, hepatomegaly, acute respiratory distress, confusion, eye pain, and large numbers of lesions, the latter being extrapolated from smallpox. And I say large number of lesions, normally more than 100 is regarded as severe, and more than 250 lesions in total is regarded as very severe. So it's not just small crops of lesions. We're talking about people that often are covered with pox lesions. These are all features that suggest an increased tendency towards complicated disease or poor outcome. And laboratory features, as you could probably imagine, going along with that, acute liver injury, hypoalbuminemia, low platelet count, and low white cell count. High white cell count. Treatment is mainly supportive. The patient should either be isolated, so either in hospital or at home, if that is appropriate, and along with supportive management, rehydration. Bacterial superinfection, as I said, is relatively common, so this should be treated if present. Contacts should be vaccinated under the auspices of public health. Antiviral therapy is mainly through compassionate use. So tecovirimat, which is licensed for both smallpox, Mpox, and indeed cowpox, and has shown efficacy in animal models from a trial that was published in the New England Journal of Medicine a number of years ago, and has had a lot of compassionate use in the 2022 outbreak of clade 2, and does seem to show anecdotal efficacy. And then other drugs that have been examined as a possibility include brincidofovir, which is if you like, an oral version of the drug cidofovir, which is a DNA polymerase inhibitor, which is highly toxic, often causes renal toxicity or electrolyte abnormalities, and it's quite poorly tolerated. Next slide, please. And this is our local policy. So just to give you a bit of a flavour for what we would do with patients that where there's a consideration around Mpox, really it's around, as Danny highlighted, having the symptoms, so having a characteristic illness with rash and the right kind of prodrome and other features, along with an epidemiological risk, and either be that travel to a place where there's ongoing clade 1 Mpox activity, or having a link to a suspected case. And if you tick both of those boxes, basically you have are regarded as having possible clade 1 Mpox. Normally, what would happen is we would, the patient would be expected to be discussed with infectious diseases on call and coordinated with the health protection team. We would arrange assessment and testing as appropriate. Some of these patients may need to be kept in hospital, especially if there are other people at home that may be at risk. But this would require full HCID PPE, so kind of the full kind of hazmat type suits, and that Pam will kind of chat a bit about later on. Obviously, if you don't meet those criteria, there's no suspicion of the HCID clade of Mpox, and you can explore other diagnoses. You may suspect clade 2 Mpox, and again, for those, some of those may be discussed with us, but if there are patients that you think have sexually transmitted clade 2 Mpox, which Kira will chat about, in discussion with the gum physician in the first instance would be the most appropriate port of call. And I think that is me, and I'll hand on to Kira.
Thanks, Nick. So I'm Kira Cunningham. I'm the lead for sexual health. Thanks. Next slide. And so, as mentioned previously, there was the outbreak in 2022 of clade 2B cases, predominantly in gay and bisexual men who have sex with men. That started in May time. And then by June, July, we saw the peak number of cases being diagnosed. So that was between 60 to 80 cases per day across the UK. Now, thankfully, due to public health measures and rapid rollout of vaccination, the case numbers really declined after September 2022 and thankfully stayed low until recently. There's been a bit of a rise in cases again in England, predominantly in London, but that's in part because they are in certain centres in London, they are doing multiplex PCR testing on anybody who presents with genital ulceration or proctitis. Next slide. So this is a chart showing case numbers diagnosed to date. So the first column shows all cases reported in 2022, and you can see that the majority were diagnosed in England, and again, it was predominantly London. Scotland had just under 100 cases diagnosed. And then pretty much through 2023 and up until the end of July 2024, very low case numbers in Scotland, so 10, with the majority being acquired out with the UK and imported in. Next slide. So we did have a very successful rollout of a vaccination program, mass vaccination of high-risk gay and bisexual men who have sex with men. And by high risk, I mean those who've had a bacterial STI in the past year and or are on HIV pre-exposure prophylaxis. We gave them a third generation, now licensed smallpox vaccine, modified vaccinia and cara, and it is a 2-dose schedule with the second dose being given at the earliest after 28 days. But there were variable supplies of the vaccine, and so at times we had to explain to people why they couldn't get it, and so we did have leaflets explaining why they had to wait for their vaccination. And when supplies were limited, the prioritization was really to give first doses. Next slide, please. So this is the rollout of the Mpox vaccination within Tayside Sexual Reproductive Health Services. And you can see from this chart, the blue bars are first doses and the red is second. So you can see that the majority of the vaccinations were given early in the campaign. We did have higher demand at that time and more supply. We were able to put on some dedicated vaccine clinics at that time with text invites going out to those who were on HIV PrEP. But you can see that uptake has waned over time. And there was a bit of a flurry towards the kind of summertime of this year, but that was when there was more kind of media coverage of clade 1 outbreaks globally. What we do feel is that we probably have reached kind of saturation point with our known cohort, certainly with those who were willing to take up the vaccine. And so our prioritization now is to complete vaccine schedules for wherever possible and to continue to vaccinate new people presenting to the service. Next slide, thank you. So what do we know about the vaccine? That it is has high vaccine effectiveness. It's around 75% effective for the first dose. And actually there's only real moderate benefit from the second dose. It goes up to the early 80s for effectiveness. The longer spacing between the doses, the better. And so it wasn't a bad thing that we did have a bit of a gap between the first and second doses at the start of the campaign. We believe that there's possibly 5 to 10 years protection after 2 doses, and that there is good cross protection across the clades. Next slide, thanks. So what do we understand about the disease presentation now following the rollout of vaccination? So as compared to what Nick has communicated, post-vaccination, what we are seeing is milder presentation with less systemic symptoms, so no prodrome. There are no extragenital lesions. People are not requiring inpatient care, and there is a lower need for antimicrobial. So this is purely for clade 2B I'm discussing. Next slide, thank you. And so within our service, we have our own pathways. Anybody who's symptomatic will come through telephone triage. They will be asked questions about symptoms or signs of Mpox by our nurse triagers. And then if they have those, they will be asked additional epidemiological risk questions for high consequence infectious diseases. And if that's identified, then we'll be speaking with ID to refer them on there. But if we think that it is probable or possible clade 2, they will remain with us. Next slide. And in those instances, we usually have a telephone consult with them. We will ask the individual to share images via WABA. They are told to isolate until we can see them and given worsening advice. But if it is a likely case, we will aim to see them face to face, to test and to alert virology and public health as appropriate. Next slide. So just our cases to date. So we have tested 24 individuals for Mpox. We had 14 presentations with proctitis and 10 with genital or other ulcerative disease. We've had 3 positive cases and 21 negatives. And as Nick explained in his differential list, we have seen that. So we've had 3 herpes, shingles, scabies, an E. coli, 3 rectal gonorrhea, and 1 individual who had rectal gonorrhea, rectal chlamydia, and syphilis. Next slide, thanks. So if you do have a gay and bisexual man who has sex with man with an unusual rash or with proctitis, we would like to see them. They can self-refer through telephone triage. Or if you'd like to phone us for advice, we have an on-call doctor advice line. And or if you have told somebody to refer and just want to relay that information, we do have an email address that you can contact us by. Next slide. And so for clade 2B, thankfully, in the current climate, it is a short self-limiting disease. It's really just about symptom control, which early in the outbreak was mostly about rectal pain. That was the main thing that tended to bring people in for inpatient care. But the majority can be safely discharged home if they're able to isolate. We do actively follow them up every 2 to 3 days to check on resolution of symptoms. And once they are asymptomatic and their lesions have all scabbed and fallen off, they can de-isolate. That's me. Thank you.
Here. So hi everyone, my name is Amanda Radley-Stewart. I'm a consultant clinical scientist in virology. I just want to give you a brief overview of Mpox testing. Next slide, please. So Mpox testing in Scotland is provided by the 2 specialist virology centres based in Glasgow and Edinburgh. It was introduced in 2022 as response to the outbreak that occurred back then. Initially, it was funded as part of the public health response, but by March 2023, it became a chargeable test, which means the boards now pay for the test. In response to the current situation in DRC, PHS have now introduced clade testing in Scotland, which means that if we have samples for either suspected non-HCID or HCID, both types can be tested in Scotland, and they can both go to those specialist virology centres. In Tayside, we now refer all our samples to Edinburgh as they went live with clade testing just this week. But just to note that samples at the moment will continue to be sent. Any positives would be sent to Ripple for sequencing for surveillance purposes, but I know that PHS are working to try to acquire funding for sequencing in Scotland as well. But the virology lab or microbiology lab here in Tayside will arrange shipment of samples for testing. Next slide, please. So the first thing that we would ask, and it's kind of following on from Kira and Nick's pathways, is, you know, if you have a suspected case, once you discuss it with the SRH or ID, that they contact the duty virologist or the on-call microbiologist out of hours before they send samples to the lab. And then once you've had that initial discussion, if you could email ta.virology with the patient details, so that would be name and CHI or NASH number and date of birth, and including in that email or discussion whether it's a suspected HCID or non-HCID. And for suspected HCID, the presumption is that you will have already discussed this case with the imported fever service in Ripple and potentially also the virus lab. The sample types that you can send for testing, ideally the optimal sample type is a vesicle or lesion swab, but for patients who present with proctitis, you can send a rectal swab. And for patients that are contacts of confirmed cases or highly probable cases who have got systemic symptoms and have not yet developed a rash, you can also send a throat swab. And all of these swabs should be collected in molecular sampling solution. So this is different to the routine sampling solution you would use for the majority of the other samples that you send to Scotland. And vials of these tubes are stored in Ward 42 and also in SRH. So obviously, if you've liaised with them, hopefully they can facilitate appropriate sampling. And each sample should be placed in a separate bag and then placed in a box that's provided. Next slide, please. And obviously, we'd also ask that you request Mpox testing on ice and make sure that the ice label is attached to the sample vial, because if it's not attached, then the lab aren't able to accept the sample for testing. And in line with what both Kira and Nick have said, because there's a broad differential for some of these patients, when we send a sample to Edinburgh, they will test the sample for Mpox, but also HSV1, 2, VZV, enterovirus, and syphilis. And I guess the only other thing we'd say is please don't use the vacuum pod for delivering samples to the lab. So for sample transport to the Edinburgh lab, if it's a suspected HCID, then we'll send that via courier urgently, and that includes out of hours. So although the Edinburgh lab don't perform testing out of hours, we would still send it out of hours to reduce the turnaround time for results being available. For non-HCID samples, they go via our routine transport provider, and they go Monday to Friday, and the cutoff Monday to Friday is 3 o'clock. At the weekends, the cutoff is 5 o'clock. Next slide, please. And I guess just to note that we can do additional testing for patients with suspected Mpox. So we can still do chlamydia and gonorrhea and NAT testing, but we would ask that samples are collected in the usual collection device. So that's the hologic aptoma collection device. Similarly, the guidance says that if necessary, testing can be done on routine blood analyzers at CL2, but we'd ask that you let the blood sciences lab know in advance for awareness, and also for them to make sure that they don't do any aerosol generating procedures on the bench. And then from discussion with microbiology colleagues, again, you can send samples for blood culture and they can plate these, but they need to do them in a safety cabinet. So ideally, again, if you can let the lab know before you send those samples so they can be processed appropriately. Next slide, please. So turnaround time. So the Edinburgh lab will do the testing once a day. They do it 7 days a week, and they need the samples to arrive in the lab before 9 o'clock for same day results. They say that the expected turnaround time is 1 to 2 days, but usually as long as the sample is in the lab by 9 o'clock, unless there's any technical issues, you should get a result by the end of the day. For sequencing, because they're still going to Ripple, the turnaround time is 4 to 7 days. But if sequencing were to become available in Scotland, we would hope that the turnaround time would be reduced. Next slide, please. So when your Mpox results are available, the virology centre in Edinburgh will either email or call the duty virologist or on-call microbiologist with the results. They tend to email if it's during working hours and if it's for non-HCID, where if it was suspected HCID, then they would call us, and particularly if it's positive. And then the duty virologist or the on-call microbiologist will notify the requester, which is usually a named GUM or ID consultant. And I guess as outlined, we would also ask that any requester should also notify the health protection teams and the infection control teams, which I think brings me on to the next presentation, which is our IPC colleagues. Thank you.
Thank you, Amanda. This part of the session relates to IPC precautions within a healthcare setting, and of course it's very dependent on your clinical risk assessment and your clinical assessment. IPC, of course, is one of the first things to consider to keep you and others safe. Next slide, please. Patient management, as noted earlier, there's two main types of clade. Clade 1 is our high consequence infectious disease, and clade 2 is where we would ask you to take transmission-based precautions. So ideally for clade 1 cases, we would wish you to directly admit the patient into a negative pressure side room. I appreciate that sometimes not always easy, depending on where your clinical assessment had been carried out. If not, it would be an appropriate side room, and also take into consideration the air changes that are available within your side rooms as well. Another thing just to consider is how you're going to get your patients from A to B. So if they've been admitted to AMU, for example, how you're going to get them to 42 or PEDS, where we have our negative pressure rooms, taking into account their patient journey and transfer and any risk mitigation that you need to take into place there. It's also beneficial to limit the number of staff that are going into a side room facility, and also utilising single-use or dedicated equipment, again, just to minimise risk as well. And of course, we would appreciate that our team, the Infection Prevention Control team, are notified of any suspected cases that you may have. Next slide, please. So I think Nick had noted about the HAZ suits. So we've got all different varieties of PPE on this slide. But for your clade 1 cases, which reiterate is a high consequence infectious disease, and that means your full PPE ensemble. That means an FFP3 mask or a hood if you are not fit tested. So a question is everybody fit tested that needs to be within the organisation and within your clinical areas? Visors, scrubs, coveralls, gloves, which are 2 pairs, not always the easiest to get on, and boots and over covers. Things I suppose are to consider here are you fit tested? Or I suppose the primary one. Also, do you know where this PPE is stored within the ward area that you are working in? And also, is there appropriate sizes for you to be able to be comfortable in this ensemble? The other PPE that you may need to look at is, if it wasn't a clade 1, which we're hoping it is not, is that you would have a clade 2 case who has respiratory symptoms. Again, those patients, we need you to wear an FFP3 mask, gown and coveralls. So again, same thing, are you fit tested to be able to see a clade 2 patient who has respiratory symptoms? So that's taking airborne precautions. If the patient is clade 2 but does not have respiratory symptoms, then we need you just to take droplet precautions, which is wearing of a fluid-resistant mask, 1 pair of gloves and an apron. So a lesser extent from the PPE ensemble. Next slide, please. Also taking into account, there is differences for our cleaning protocols as well. So we are asking you to utilise a chlorine-based solution. So it's a bleach solution, and it has to be a certain concentration and contact time. Again, it's useful to know that where that is stored within your clinical areas, so that you have that support available. If you're unable to use disposable kit, then you also need to clean any equipment that is utilised with a chlorine-based solution. And when the patient is either transferred or discharged, that side room facility will need a terminal clean before any other patient can be admitted into that area. Next slide, please. Our waste management, there's been some changes back and forwards since the Mpox guidance has been developed. So the most recent guidance is that normal waste stream is acceptable, so everything can go into the orange waste stream, bar any viral cultures which need to go for incineration. So again, very important that we keep on top of the guidelines because they can change quite frequently. Next slide, please. Linen is slightly stricter actually than the waste. So we actually ask you to quarantine linen until we are aware of what the clade group is for that particular patient cohort. If it is a clade 1 case, then we're actually advising that that linen is binned as through the waste stream, and if it is clade 2 cases, then we wish you to put that through the red linen stream for infectious waste. So it's holding the linen until you know the clade case. If it unfortunately comes back as clade 1, then we want you to just actually bin the linen more than anything else. Next slide, please. Vaccination's been touched on through the discussions earlier, and we just actually ask for standard precautions for vaccination. There's no real change in the PPE required unless there's a local risk assessment carried out by whoever's vaccinating the contacts or staff or other case groups. Next slide, please. So in summary, clade 1 is a high consequence infectious disease. It's about the full PPE ensemble as noted and strict isolation. For our clade 2 cases, we want you to follow transmission-based precautions and of course link with all the members that are probably providing some of the sessions today, but my plea is to contact ourselves as part of the IPC team. Next slide, please. And finally, about just really asking you all to be prepared. I know this session is about Mpox, but it's about being prepared for all high consequence infectious diseases, reiterating that early identification and IPC measures are key to preventing any high consequence infectious disease spread within healthcare, and also to be mindful of the guidance and how frequently it can change. So we've been mindful of that through COVID and other organisms, so it's no different with Mpox, and being vigilant for any changes and updates that will normally be shared through our communication routes. I have also put some links, so there is a high consequence infectious disease video that is available, which I've noted, and that goes through the donning and doffing of PPE for high consequence infectious diseases. And we've also noted the link to the most recent Mpox guidelines, and of course just being mindful that that can change as well from that point. Thank you very much for your time.
Thanks everyone. Thanks Tom. I don't know if there's any burning questions. I can't see the chat at all.
Yeah, thanks everyone. No questions in the chat just now, and we're just bouncing against the time limit for the ground round. So lots of information, and thanks very much for the team effort. If anyone does have any particular questions, they can get in touch with me and I'll forward them on, or you can follow the advice given by the members of the team as we went along. So I think that's it for today, and I will send you a summary of what's happening next at the next grand round, which will be when we celebrate Black History Month. So we have a grand round organised where some of our students from Black and minority ethnic background will be talking about their experiences in medicine, medical school and more. So do join us for that. But for now, thanks very much to all of our speakers, and I'll see you all next time.